So I came to this meeting of personalized medicine to maybe be, I think, give an opposing view that personalized cancer medicine or precision cancer medicine, if you choose to call it, is not something that we are in a position yet to be doing as we're doing it, and to basically encourage individuals to enroll in clinical trials, to enroll their patients in clinical trial, and not to do what is generally referred to as giving drugs off-label to patients with cancer. I think we're not in a position to be doing it because we don't know enough. And we don't know enough because we had preliminary data and we thought it could be extrapolated in ways that clearly, as we go deeper and deeper into it, we find that was incorrect. That our ideas that we could look for a mutation, find it in a tumor, and think that because we had a drug that had great impact in another cancer with that mutation, that we would achieve the same in this setting. That BRAF mutation in colorectal cancer means the same that a BRAF mutation in melanoma. And we know that that's not the case. And a BRAF mutation in a random individual, in a random cancer found in an individual, is unlikely to mean what it means in melanoma. And we shouldn't be giving a BRAF drug such as vemurafenib to patients with those results. And in doing that, what we're doing is we're conducting, in essence, a clinical trial in an individual, but not capturing the data. So certainly in the United States, we're guilty of that, probably more guilty of that than anybody else in the world, that we're doing that. And in the course of a week, we would probably have all the clinical data we need to make a lot of informed decisions, but we don't have it because it's being lost. How often is it happening? Very often, but I can't tell you how often, but it's very, very often. I mean, certainly very often the tumor is being sent off for an analysis of the genomic profile of this tumor. And that varies from, looking at just a few genes to a larger panel to even some individuals send it for deep sequencing to basically look at the entire genome. Some of this depends on what your insurance covers or what you can afford. But it's happening in thousands and thousands of patients. And you can't help but thinking that once you get that information, you do something with it. So I don't think physicians and patients are sending it off, and then it comes back that you've got a mutation and you don't do anything about it. But you've asked me a question that I can't answer because we're not capturing that data. Even the largest sort of organization that does that, or business that does that, which is Foundation One, it doesn't properly capture the data, and they could. Foundation One, in 1 year, could get us all the information that we're trying to get with any number of clinical trials. And we'd be done with gathering that information and could make decisions to then move forward, but we don't have that. I think the ideal situation is if a patient comes to you and says they want to have their tumor profile because they've heard or read in the newspaper or heard on a TV show or on the radio that, oh, this is done, and then they can give you a medicine that will help, that you tell them that, we don't have evidence for that. But we'll go ahead and do it. And then if we find the mutation, I'm going to work as hard as I possibly can to find a clinical trial that you would be eligible for so that you can enroll. And if that can't happen, I shouldn't be giving you this because every cancer therapy has side effects, and those are predictable. I can guarantee that you will have the side effects that we know for this therapy, but I cannot guarantee that you will have any benefit or that the benefit will be enough to offset the side effects. So unless we can enroll you on a clinical trial, where at least we'll have information that will be valuable to you and to the rest of cancer patients that come after you, we should not do this.